In this video, I'm going to help you understand what the spinal cord is, what it's made of, and some of its most basic functions. What we see here right at the outset is a really great picture. Very high level of magnification here. This is a scanning electron microscopy of a cross-section of the spinal cord. And what we're actually looking at are individual neurons. The orangish part in the middle represents the axon, and the sort of bluish-white coating wrapping around it represents myelin. You might remember myelin from the last chapter, a fatty insulation that wraps around axons to dramatically increase the speed of the action potential. And so here we have 100 or so myelinated axons. The spinal cord would encompass a much, much greater section. We're just looking at a tiny, tiny little thread of the spinal cord. But it gets us started in thinking that the spinal cord is a bit like a highway system. We have northbound traffic, sensory or afferent information coming in from the skin, from joint position sensors, from hot and cold thermoreceptors. Incoming information is sometimes called ascending information when we talk about the spinal cord, because it's coming in and up to the brain. On the other hand, descending information originates in the brain. You could think of this as motor signals or efferent signals, originating in the brain and then coming down and out to command glands or muscles for movement. So this is a major theme of this chapter, to think about the spinal cord as having both sensory and motor fibers that contribute to it. Spinal cord injuries, of course, are very serious, sometimes life-threatening if they're at very high levels, because they could paralyze the breathing muscles like the diaphragm. But spinal cord injuries are not always life-threatening, and they're not always as complete or dramatic as we think about with paraplegia or quadriplegia. A small spinal cord injury, a relatively slight one, could result in just motor dysfunction or just sensory dysfunction. Obviously, a more severe complete transection of the cord prevents any information from getting past that injury, and so someone here who has a T6 or T7 spinal cord injury may lose all sensation and control below that segment. And if you think about why that is, motor signals can't get past that injury, and so the patient is going to have weakness or paralysis. Maybe they'll be able to move their face, neck, shoulders, and arms, but at T7, they're going to have a very difficult time moving the trunk, and obviously no movement of the legs. Likewise, sensory information, even though there may be nothing wrong with the skin down here, to the patient with a T7 transection, they're going to have loss of sensation. Sensory information coming up bilaterally won't be able to get past that injury, and so without any afferent signals reaching the brain, they have no conscious awareness of any part of their body below that injury. You can see here anatomically the spinal cord is divided up into those same regions that we had learned about when we were talking about the spinal column, the skeletal part of the spine: cervical, thoracic, lumbar, and sacral. There are 31 pairs of spinal nerves. That's what these little yellow sections coming off represent. And those spinal nerves are always mixed, carrying both sensory and motor information. Strangely, there are 8 pairs of cervical spinal nerves. I know there are only 7 cervical vertebrae, but there are actually 8 pairs of cervical spinal nerves. We'll look at that in a different video. I'll help you understand how to count them. 12 pairs of thoracic, 5 lumbar, 5 sacral, and then some coccygeals that come down to innervate the perineum. A couple of other interesting anatomical structures. The cervical enlargement is just that. The cervical spinal cord at that section is slightly larger in diameter, and that correlates with the increased amount of traffic and increased physical volume of the connections, the synapses there. Down below, the lumbar enlargement, correlating with increased traffic and physical volume of the spinal cord. It's actually around T10 or T11, but we don't call it the thoracic enlargement because it's actually the lumbar spinal nerves that are synapsing there that contribute to that change. Next, anatomically, we have the meninges. The meninges are a protective membrane that wraps around the spinal cord and produces a fluid called cerebrospinal fluid. Sorry, I had to shut my door there. Cerebrospinal fluid surrounds and protects both the brain and the spinal cord. It's actually produced up in the brain, and then through some very clever plumbing, the fluid actually flows all the way down and around the cord. Then you can see the layers of the meninges include dura mater, arachnoid mater, and pia mater. The word mater means mother in German. So dura, like the word durable, means tough. So the dura mater is one tough mother. Seems like there should be one more word there, but there's not. It's just dura mater. Arachnoid mater means spider-like mother. I don't like those two words even in the same sentence, but it refers to these tiny spiderweb-like denticulate ligaments that prop the arachnoid up away from the innermost and most delicate pia mater, and that potential space there is filled with cerebrospinal fluid, CSF. So to make just a quick clinical connection, you might recognize the word meninges as in meningitis. So if you had a patient with suspected meningitis, you would have the opportunity, I suppose, theoretically, to sample cerebrospinal fluid from their brain. And so you could theoretically drill a hole in the patient's skull to get at the cerebrospinal fluid, but you probably know that's not how they do it. They do a lumbar puncture, right? Having the patient in a seated or side-lying position, slightly flexed to bring those spinous processes apart in the lumbar spine. And the whole point of my story here is because the cerebrospinal fluid is all one convoluted fluid column, whether we're sampling from the lumbar spine or the ventricles in the brain or the subarachnoid space deep to the skull, it doesn't really matter. It's all the same fluid. And so by doing that spinal tap, as it's sometimes called, or lumbar puncture, the physician can get a sample of this fluid and then run tests on it, culture it, look for viruses, look for DNA of pathogens, and that can help, obviously, with both the diagnosis and the treatment of a meningitis. Back to the overview, just really quickly, there's a couple of other things I want to point out. The conus medullaris, right about here, maybe say L2-ish, is the end of the actual proper cord, the gray and white matter, and the end of the meninges, the way that they are wrapped around the cord, as we had seen in the previous picture. Below the conus medullaris is the horse's tail, cauda equina. Cauda meaning tail, equine meaning horse. There is no gray and white matter down here. These are just a loose collection of spinal nerves that haven't yet synapsed together into this gray and white matter pattern, which you may have noticed from this other picture here, looking a bit like a butterfly or a bat. This gray X is called gray matter, and then the pinkish material surrounding it is called white matter. Although it doesn't appear quite this color in a cross-section of a cord, it would be a little bit more ivory or off-white. White matter is white because of the amount of myelin. Gray matter is gray because of the amount of protein. And this is a really important concept that we will be revisiting a little bit later in the next video.